Hello and welcome. My name is Raj Persaud and I'm a consultant psychiatrist based in London. And welcome to Headstarters Part 4. This is a series where I talk to young psychiatrists, psychiatrists in training, about what it's like to choose psychiatry as a career, or what is it like to be in training as a psychiatrist. And joining me today are Amanda and David, and we've changed their names, those aren't their real names, in order to preserve their anonymity. So what we're going to talk about today is in what way is psychiatry different from the rest of medicine? Because that's one of the things that seems to have quite an impact as to whether people choose psychiatry or not when they're medical students or young doctors in training. And there is meant to be a kind of recruitment crisis in that medical students and young doctors are not choosing psychiatry in the same numbers as before. And one of the reasons that I got interested and chose psychiatry was one of the key ways in which it was different from the rest of medicine was I was rather shocked as a medical student to arrive on the wards and discover how old all the patients were. Everyone was like incredibly old and very ill. And maybe I shouldn't have been surprised by that. But then I arrived and did psychiatry, and everyone was like incredibly young. And basically, the peak age of developing psychosis is when you're in your late teens and early 20s. So the wards were full of young people, and that kind of like attracted me and drew me towards the subject. But Amanda and David, maybe you first, Amanda. What differences did you notice, and did those differences attract you or repel you in terms of psychiatry?
I think there are quite a lot of differences between psychiatry and other specialties, as well as similarities. And I guess one of the things that attracted me to psychiatry was this idea that actually things aren't necessarily 100% clear cut, that the cut-off between what we call normal and what we call ill is really very socially determined. It varies not only in kind of different countries, but different cultures, and people and psychiatrists themselves have different ideas about where we should draw that line. And I think that reflects a bigger difference between psychiatry and other specialties, in that psychiatrists have to deal with a lot of uncertainty, not only with kind of diagnostic classification, but also uncertainty about treatment. And that uncertainty gives room to a lot of controversy, which you don't necessarily get in other medical specialties, although obviously there are cut-offs that are determined, for example, HbA1c as a marker of diabetes, or blood pressure, and saying when we treat that is essentially an arbitrary cut-off that's used. But there's almost something about how that is derived and the idea that there's a test behind it that we can use to find that cutoff. Whereas in, say, someone with mental health problems, say somebody who's hearing voices, when do we actually say that person has got schizophrenia? Is it based on, there's no test, there's no place that we can actually draw the line. So do we base it on a symptom count, or how they're functioning, whether they can work, or the distress it's causing them, or the risk? There's so many different variables, and I think that kind of uncertainty is something that's really interesting and does slightly separate psychiatry from other specialties.
David, what are your thoughts?
Well, I'd just like to echo that, and just add that interplay between ethics and the legal side of things.
Yeah, go on, sorry.
And it's that interplay with people who aren't aware of their own illnesses, and that is a major difference. People who have COPD get short of breath, want to feel less out of breath, whereas someone with perhaps, say, a psychosis won't necessarily realize that actually their illness is having such a profound effect on not only them but also their wider family and the wider society. And that ethical and legal dilemma of when do you intervene, or when do you try and help someone who has that lack of insight adds to, I suppose, the variety of psychiatry as well.
I want to pick up on that point because there's a theme there I think that unites both of you in that perspective, which is the fact that I think in psychiatry there's a lot of negotiation, much more than in the rest of medicine. When the patient comes, the diagnosis is a negotiation in a way, or even what diagnosis is. Then the treatment is much more of a negotiation, and even whether they come back or not, or how the treatment is played out, or when the end point of treatment is much more of a negotiation. In the rest of medicine, people say, what's the diagnosis, doc? And there is no negotiation. The blood test reveals it, or the chest x-ray reveals it. And then they say, what's the treatment? And there's relatively little negotiation over that, because usually there are these, in my view, terrible things called nice guidelines and so on, which kind of dictate the treatment from the off. So there's much less negotiation, and maybe one of the things that separates people who are drawn to psychiatry compared to the other specialties is this desire to negotiate, or this comfortableness with negotiation. I don't know what either of you two, what your thoughts are about that.
I mean, the challenge, or the challenges that we face on a day-to-day basis are numerous, and that is one of the major challenges. But I think that's part of the beauty of psychiatry, because of that variety in not only the negotiation side of things, the challenge that Amanda mentioned about sort of getting the diagnosis or understanding what the diagnosis is, and then the negotiation about how best to involve the person in actually implementing these treatment plans. It all provides massive challenges, and that is one of the key reasons why I went into psychiatry, because I didn't want to just sit on my backside, do a blood test, and not engage my brain, and not engage.
Ooh, I can feel other doctors getting a bit annoyed by that comment.
No. I'm afraid to say, cardiologists do an ECG, there we go, done and dusted. There is no intricacy between sort of having to talk to the patient, trying to understand where the patient's coming from, trying to involve them, understand that actually patients won't necessarily want your treatments. I mean, we get calls as SPRs on call from medics constantly asking, well, can you help us with this capacity assessment, because this person doesn't want to go ahead with that procedure or this procedure. And it's, I suppose, psychiatry's understanding of the interplay of a right of an individual to self-determine, balanced with the rights and expectations, the ethical principles that guide us as doctors. And that is beautiful, I think, and why I love psychiatry.
And I think it is partly to do with an acceptance that actually doctors don't have to be completely paternalistic as well, that actually doctors can be wrong sometimes and they don't have to have all the answers. And I think other branches of medicine, although doctors certainly don't have all the answers, and there's so many times that actually they don't know what's going on, but it's really difficult to accept that, and it's really difficult for doctors to say, actually, look, we're not sure, we're unable to say what's causing your symptoms. And I think in psychiatry there's much more acceptance of that, because there's much more recognition of the idea that things aren't entirely clear-cut. And I think actually that is a skill that we've kind of honed in psychiatry, or we've had to, which is why we get called on call or in our jobs to help with capacity assessments and those sorts of things, because actually understanding that things are on a spectrum is part of our day-to-day work. And I think in other specialties that's really not emphasised, how complex things can be and how uncertain things can be. But it's something that we have to deal with and we have to see.
As well as the fears that a lot of patients actually do go through. I mean, we deal with this day to day. And sometimes our physician colleagues just don't quite get it. And I have had calls where people or doctors have expected, well, I can't believe that this patient isn't going ahead with this procedure. But obviously they're trying to save their life. I don't understand.
But I think also, to be fair, doctors are very varied in any specialty, aren't they? And people and doctors are vary in how paternalistic they are and how much they feel that the autonomy of a patient should kind of triumph, really. And so I think no specialty kind of has a monopoly on being paternalistic or respecting autonomy. It's just an individual thing, really, isn't it?
But I want to go back to another thing.
Maybe I've just come off the spate of a bad set of on-calls then.
But I want to go back to another thing that I think is a big divide between psychiatry and the rest of medicine, and that's the notion of woolliness. A number of times patients and doctors have said to me, this is too woolly. And I think there's something interesting. I was discussing with a patient today coping skills, and I was laying out what are the best coping skills to deal with a particular stressful event, and which are not and what aren't helpful coping skills. And to me, the discussion about coping skills was not woolly. It was vital and pragmatic. And it was fascinating that to other people, a conversation about coping skills is woolly, but these are people who like to look down a microscope and at the histology specimen and see the object that is being treated. And maybe the thing that differentiates psychiatrists is that their understanding of what is woolly and what isn't is different.
I think that goes back to what Amanda and yourself have been talking about, the uncertainty of reality, basically. You know, seeing a distinct object, you could say, that is E. coli, I'm going to treat that with X antibiotic. However, what we deal with is invariably woolly, or should we say uncertain. And I think there is no shame in admitting that actually things can be uncertain, but how do we best deal with it?
And I think partly it's to do with the portrayal of doctors as being people that should fix things. So patients know that they're going to come and see a doctor, and some patients think, well, I've got all these problems, and often they're really pervasive, difficult things in multiple areas of their life, and then they come and see a doctor and they think, perhaps I should be able to get a pill and that should fix it. Now, that's by no means the majority, but there are some patients that who hold that belief, and I think that's our own fault as a medical profession for kind of portraying this idea that we're doctors, we fix things. If you break your hip, we'll give you an operation and put it back together. If you have a mental health problem, we'll give you something and it'll sort it out. And I guess that partly comes back to Dave's point about how psychiatry links with kind of other specialties. But also I think we play a role in that and propagating that idea. And actually a lot of kind of the psychiatry movement at the moment, I think, is trying to escape this idea of woolliness and uncertainty, like in the US with the National Institute of Mental Health putting a huge onus on treating symptoms with a biological etiology and going kind of down that route. So trying to mimic other medical specialties in psychiatry. And I just don't know how well that fits, whether we've got enough kind of research, and obviously there's a lot of funding going into it at the moment, particularly in the US, but whether we actually have enough evidence for that approach at the moment, whether actually we do need the diagnostic classifications that we have at the moment, because actually other methods are less valid at the moment because we don't have the evidence to back them up.
David, did you want to come back on that?
I mean, I pretty much agree with what Amanda says there. It all stands to reason. I mean, that's the difficulty and beauty of psychiatry in a short statement. Diagnoses are constantly being reviewed. I mean, let's face it, in medicine, they're being reviewed full stop. But within psychiatry, where there is such a, should we say, limited understanding of exactly how the brain works, because let's face it, the brain is the most complex organ that a human has, that we are constantly shaping and molding our understanding, and hence the diagnostic classifications. And yes, there is a drive within certain areas of the psychiatric community to lean towards a more biologically focused approach, but it would sort of completely disregard the quite obvious psychological and social elements of a person developing a particular condition, and that's the debate that is pervasive through psychiatry, and I think one that all clinicians can be involved in.
So we're running out of time a little bit, and I want to just focus on the thing that both of you have mentioned, but Amanda in particular, this notion of fixing things. I think people are drawn to medicine because they want to fix things and they want to help people, and they're usually brilliant problem solvers. Now, in psychiatry, because there's often the passage of time during which time people get better, there's more controversy as to exactly who fixed what. In the sense that I had a patient today, for example, who's definitely a lot better and made a complete recovery from a pretty serious psychiatric disorder. But they did say quite intelligently, but you know, was it you who got me better, or was it just the passage of time? And you can never really answer that question definitively in psychiatry. But in the rest of medicine, someone comes in through casualty in an ambulance with acute abdominal pain. The surgeons go in and take out some horrible tumour, and it's definitely the case that the passage of time would not have been helpful if it wasn't for surgical intervention. And in the rest of medicine, it's pretty clear cut that the doctors are fixing something, and the doctors are the persons that are responsible for the person getting better. In psychiatry, it's not quite so clear cut, is it?
No, but I think in the rest of medicine, the flip side of that is when patients don't get better. For example, say they don't comply with the medication regime that the doctor has set out for them for millions of reasons, then actually that's not the doctor's responsibility. So patients, if they get better, then the doctor's done well. But if they don't, then actually the fault is with the patient, or they might be referred to see a psychiatrist, for example, because clearly they're not engaging in the way that's expected. Whereas in psychiatry, I don't think you get that as much, because you're dealing with people with mental health problems. I guess if a patient doesn't get better, it's not kind of as accepted that perhaps there's something going on with that patient, but again, you're kind of held responsible for that. And so I think it's a difficult thing. Yeah, sorry, go ahead, David.
No, to a certain extent. I just want to go back to the original point that medics cure things. I don't think they do on the most part. If you think about diabetes, what they actually, I'm just plucking out thin air, but you don't actually cure diabetes per se. You treat the consequences of having high blood sugars, and you also try to control it. And I think the same is true for a lot of medical specialties. You don't actually have a cure, you have a treatment which tries to resolve symptoms. And I think psychiatry in that respect is very similar. I mean, we do have treatments within psychiatry which are recognized as being as effective as some treatments within medicine. For example, clozapine for psychosis, ECT, and lithium are just examples that I've plucked out there, and they are very effective treatments. And we do know other therapies like CBT, for example, can equally be effective. So yes, they're not cures per se, but they are still treatments, and which are very effective. So I don't think there's a huge deal of disparity in that respect. But like Amanda said, it's that sort of appreciation that actually there is an onus on the patient to be involved and take a certain degree of responsibility without it completely being, shall we say, the fault of the psychiatrist if a person doesn't get well. Because let's face it, there are a sad, small proportion of people that just don't respond to treatment for one reason or another.
Yeah, but you said, and it may have been a slip of the tongue, that there are no cures. I'm paraphrasing what you said. I mean, I believe in psychiatry we do cure people. I know that's not a very fashionable thing to say, but I think people get completely well and they make a complete recovery. Sometimes they may relapse in the future, but that doesn't belie the fact that they made a complete recovery first time round, and do so repeatedly in the future as well.
And maybe that's just a question of semantics here, because when I'm talking about sort of cure, I'm being completely rid of a disease process. Like, for example, if someone has appendicitis, take the appendix out, there we go, you are cured. Whereas this is a treatment, as I see it, which helps control symptoms, and the symptoms can have completely abated, but I wouldn't necessarily say that person was cured per se.
So they might have gone into remission, but not necessarily if you stop the treatment. I guess lithium is a prime example, isn't it? If they stop the treatment, then the risk of relapse is pretty high, actually.
Yeah.
Yeah. Okay.
But nonetheless, we can make a hell of a difference to people's lives, and it is quite phenomenal how, and I'm sure all of us have experienced this, people are in the depths of depression or psychosis, and then having a treatment, be it medication, psychology, or even social support, making so much of a difference to a person's life, to the extent where they're functioning normally, they're living normal lives, and it does bring a great sense of well-being. And I suppose in a backhanded way in psychiatry, because it's quite phenomenal seeing patients who are cursing you and telling you you're a useless doctor who doesn't know what they're doing, how dare you section me, how dare you force this treatment on me, and then seeing them a few weeks later going, I can't believe I said that, I'm really sorry, you know, you've made a massive difference to me and my family's life, and it is really quite touching in that respect to see that change.
And I think Raj's point right at the start about the age of patients, that's one of the most rewarding things, when you can turn someone's illness around at such a time of their life, like their early 20s, late adolescence, when they've got so much kind of going for them. Then actually it allows them to make so much of their life, managing to get back into kind of education, getting into work, forming relationships, and all these things can come of kind of effectively managing what can be illnesses that are quite devastating for a person and for their family otherwise in some cases.
Wholeheartedly agree. I mean, it's such a key part in someone's life when they are young, when they're forming these relationships and forming their way in life, and you can make a hell of a difference, in shaping that positively.
David and Amanda, we've run out of time, I'm afraid, but thank you very much indeed for joining us for Headstarters, and we hope to record another one of these in the very near future. Thank you very much for joining us.
Thanks very much.
Cheers.